got Dr. Hiremath live. I think Dr. Rathore, you can set the ball rolling.
Dr. Hiremath, this is Dr. Rakesh Sharma from... Are you there?
Yes, very much. Very much. You guys are having lunch. We had no lunch.
No, we also skipped the lunch for you.
Oh, that's good. Appreciate it.
To observe a nice case, skip the lunch.
Good.
Okay,
So,
Dr. Hiremath, this is Sudhir here, Sudhir Rathore. You're live on. Would you like to present your case, please?
yes, I have with me Dr. Narasa Raju. I'm in care at the Banjara Hills. And Dr. Narasa Raju will give the story to you.
Yeah, good afternoon, everybody. This is a 54-year-old gentleman with unstable angina and ECG changes in the anterior leads. And his LV function is normal, enzymes are normal. So we did the angio.
So we'll show you the angio directly. The right corner is normal, dominant. Yeah. And can we show the image? Can we show the cine run? So the guide catheter is a 7 French EBU. In Hyderabad, it's very difficult to find EBU 3.5, they told me. You get only 3.0. So we managed to get it in. It's all a radial city, so to say, and Dr. Narasa Raju was telling me that he would definitely do this case radial. But me being from Pune, I thought we'll go from groin. So this is the first image for you. Next run. So we have, can we freeze this? So we have a very big diameter left main lesion at the distality. Critical lesion after the origin of the circumflex, a big size diagonal, and the vessels distally look very, very clean. Overall, the vessel diameters are quite large. Next run, please. So this is epicranial for you. Can you freeze that again? All right, so it's a sort of a focal lesion involving distality of the left main and orchial LED. Next. This view doesn't seem to contribute a lot. Can you go back one frame? So Sudhir, we were going to borrow your wisdom as we start doing the case. Previous run, yeah, freeze that. So what do you think? As we see, there are 2 side branches, previous view, and both seem to have no disease at the osseum. That's the background. So can we freeze this? So any guidelines or help that you want to give us?
Well, I think it's a great case and great. So there are 2 or 3 points to pick up here. One, the left main is a long left main stem. Second thing is it's a bifurcation, but the circumflex ostium looks free of any significant disease, and it is non-dominant. And the diagonal branch looks also free of significant disease. So approach for me will be a crossover stent from left main stem, not covering the whole left main stem from mid till proximal left anterior descending coronary artery with wire in the circumflex. And then if the result is good, then just proximal optimization. And if the side branch is pinched more than 50%, then the kissing balloon could be done. So that will be my approach.
All right, we always, when we have left main as a lesion, we always talk of antiplatelet first, because we don't do clopidogrel testing on regular basis. So we don't want this patient, if at all he comes back with a stent thrombosis, it can be a disaster. So my choice generally would be ticagrelor or prasugrel in this case. But many would agree that this is a trop negative, sort of a stable case, recent angina, and clopidogrel also may work equally good. Second point was balloon pump. Ventricle is normal, so we discussed and we thought there was no need for balloon pump at this stage. Patient is well sedated, and we now need to think whether you want to wire in LED, of course, but would you wire these 2 side branches? We have circumflex, which is non-dominant, very mildly diseased at the osseum, and we have diagonal, which is big-sized, but no disease at the osseum.
How do you want to assess circumflex ostium? Because it doesn't, it's at least borderline.
All right, but if it is diseased, does it change your decision? You would want to wire it? I mean, it's not a big vessel, so All right, so we discussed and we thought we will not wire it. So we have a wire coming in, next run. And then this is a non-compliant balloon, 3O. We went to 16 atmospheric pressure, next. The balloon was slipping a bit, next. And this is the IVUS. So we are now going to run the IVUS images for you. See, a few points here are whether there is a disease at the mouth of the side branch. Secondly, the diameter, whether the stent is going to really match the diameter of left main, especially at the back end. And how we are going to achieve the diameter. Today, our largest post-dilatation balloon is only 4O. So we have to think how we can ultimately match the diameter. So we'll run the IVUS for you. Can we run the IVUS? You want to comment? So this is distal LAD, which is between 3.5 and 4. 3.5 definitely.
More proximally, it is around 4. That's the area just before the diagonal. And as we come to this is the distal left main lesion. You can see the ostial LAD distal left main lesion. That's the circumflex coming there. That's the distal left main. And the vessel is around 4.5 here. And as we come more proximally into the left main, the left main seems to be normal. So it's like from the mid of left main to ostium of LAD is the plaque.
And the diameter of the left main. I think that's going to be an important issue because we absolutely need to oppose the stent to the vessel wall, and the diameter of left main in the mid shaft and ostial area is nearing 5. So,
Dr. Hiremath?
Yes.
Yes, so obviously the IVUS shows that the proximal LAD is around 3.5 to 4 and 4.5 to 5 left main stem. So what is your strategy in terms of length of, like, will you be stenting from ostium into proximal LAD, or would you end in the shaft of the left main stem here?
No. Here, I think the left main is very long.
Oh, yes.
And I think we have almost half the left main free of disease. So I wouldn't worry to come back to the ostium, especially since the IVUS is showing that from mid-shaft backward to the ostium, the left main has no disease at all.
I agree, yeah.
So we would be stenting just show us run number 2 again here. We would be stenting just where the lesion is, say mid-shaft to covering the lesion into the LAD. You still haven't answered our question whether to wire the side branches.
I think I will wire the side branch. But you can see the circumflex ostium from the pullback from the ostial LAD. It is not significantly diseased, but I think wiring just provides a protection in case if there's a significant plaque shift, which is very unusual because the plaque distribution is more on the opposite side of the left circumflex ostium. But I would wire it just in case, but I think the crossover stenting which you're planning will be completely appropriate. Any more comments from the panel?
I think so. That should be the strategy, putting 3 wire in LCX, diagonal, and the LAD. And we have an IVUS finding, and we have to be single stent strategy, that is provincial strategy, and look for it how it looks like in the OM1 and LCX. I'm mainly concerned on the OM, that is diagonal, that is a very big size vessel. But if we want to do something, we may have a guidance of the FFR if there is a plaque shifting or light, then we can deal with that.
Diagonal wire can be avoided. Circumflex, yes, a software will be better.
The dictum is you should never lose a vessel acutely. If you lose a vessel, like say total block and CK leak, this has a clear long-term bearing. So I would be also very concerned whether to sort of protect the side branches. But here, the diagonal is absolutely free of disease, and circumflex is relatively small, a very dominant large right coronary. So we are going ahead with no wire in the side branches. We are now taking Ulti-Master stent. The Ulti-Master stent, as you know, has 80 micron thickness. It has two connectors, so it's very friendly on the side branches. You can actually deploy the stent, go through these struts, and open up the mouth on the side, and you can get an access which is 3.0, can give you a 4+ access on the side branch.
Dr. Hiremath, you have got 6 more minutes, then we'll come back to you.
Yes.
6 more minutes.
All right, so this stent has abdominal coating. The results are very striking. The EuroPCR online data suggests that at the end of 1 month, we have almost 80%, 85% stent covered, which is exciting, allowing you to stop the antiplatelets, one of the antiplatelets early if you want to, and 95% coverage at the end of 3 months.
MS, this is Rajiv Lochan. What's the length you have chosen, and what's the diameter of
Can we
the
go
stent?
to this view? So we have 4 into 24. The IVUS actually indicated the length of the lesion was 17. So we have enough length on either side.
Don't you think the 4 is a little extra for the bigger for the distal vessel, LED?
No, we saw the LED.
Or 3.5 or 3.2?
So Rajiv, you arrived on the scene late. You should have told me earlier. I would have taken 3.5. So
Okay.
it's 4.0, and see, we have to go very high on the proximal portion.
Yes.
I think we're okay.
We're okay.
We go up, so quickly to 3 and gently to 8.
I'm
Okay,
at
we
10.
stop.
10.
8. Enough. So this is a 4.0 going to 8 and 10.
We have stent boost.
Oh, we'll do it later. Will you be able to show the stent boost or no? It's difficult to show them. So we'll take a picture at this stage. Sorry.
Good size.
Yeah, I think matching, get a 4.0 balloon, please.
Shorter
4.8.
You need a short balloon?
Yes,
We are taking 4.8,
Is it compliant or non-compliant?
non-compliant balloon.
non-compliant.
NC Trek.
So we'll do dilatation with a 4.0 balloon. Then we will take an IVUS, look at the side branch. If they're flowing well, as they are just now, I think we are okay. But at some stage, we are going to do IVUS to see if the stent is well opposed. This particular stent can be stretched, 4.0 can go to well beyond 5. So we are hoping that we'll have a very good opposition at the end of a high pressure inflections.
This is non-compliant 4.0 balloon, so how best we can achieve close to 5?
So you can. So I'm going to ask you. So we discussed a little bit because we knew that we did not have a 4.5 or 5.0 stent. So the next we may opt for is put one more wire and have 2 balloons and go up simultaneously in the back portion so as to stretch the stent. So we very rarely do it whenever a big balloon diameter is not available. A 4.0 compliant balloon may help.
possibility.
Yeah, non-compliant, compliant balloon can increase the size, yeah.
Compliant can increase and swell in the size. So,
But compliant balloon is not good for post-dilatation.
yes.
Radial force is not good.
So we are taking a non-compliant balloon, but if the IVUS still shows that you're not at it,
Okay, Hiremath, I have one more query. I am Abjal from Bangladesh.
yes.
That regarding the carina shifting, if you choose the
Okay.
stent little bit oversizing of the distal vessel, then there will be more carina shift. You don't believe on that?
8. No.
Because we can have and take the 3.5 and there should not be any carina shift. What do you think? And there is some pinching on the LCX, whether it is due to plaque shifting or carina shift.
Okay, okay, let's go. So, no more. Go to 10, 12, 14.
Last 1 minute for you, Dr. Hiremath, then come
Okay.
back to you again.
Okay.
I think the issue here is the proximal, proximal stent, which is in left main stem. That has to
Okay.
go up to at least 4.55. We have to do the IVUS and see. And a compliant balloon might be used to increase the size, isn't it? Because, or maybe 2 balloons if you don't have bigger size balloon.
Okay, get ready for stent boost. So we are using a stent boost to mark the back end. We look in good position.
Shall I?
Let's go.
Shall I go ahead?
Yeah, go ahead.
Go ahead, dilate. 8, 10,
No, go
12,
20, 22,
20,
24,
24.
26.
I'm at 26.
Okay. So we'll quickly take a picture before you leave us and go. And go. Ready with contrast?
Yeah, ready with contrast.
Small. So go LA caudal, please. We said we'll balloon dilate the stent. So this stent has the ability to be stretched. This was a 4.0. The Ultimaster could be stretched to 5.3. This was a 4 into 8 length NC balloon. This is an Abbott balloon.
NC track.
NC track. The distal part of the stent was dilated to about 10, 12. Proximal, we went to 26, 28. And we will now show you the images, angio. So we have this image, looks pretty good, well expanded. On either side, actually, the vessel looks matching to the diameter of the stent. Slowly, step by step. Okay. All right, we'll show you the IVUS at this stage. Can we go to IVUS? So this vessel distally beyond the stent also is about 3.7, 3.8. So at this part, the stent looks well opposed. See, the cross-sectional area at the tightest portion is 7.8. The left main area, the stented area is 12.5. And the LAD in the sort of proximal portion beyond the ostium, where the diagonal is coming out, next run, is about, is about 8. So I think cross-sectional area looks very good. So the stent looks well expanded, well opposed. We come back to cine. These are the cross-sectional areas. This is left main, which is 12.5. 12.5. So we go back to the cine. So having got a good result on the IVUS, we thought we'll look at the side branches, both on IVUS and an angio. And these are the angio pictures where the flow is very good, no extra pinching. Next. So at this stage, we feel everything looks very satisfactory. I mean, our main concerns in this case were the side branches and the position of the stent. This particular stent, Ultimaster, in the comparison with Zions in the Centuries 2 study, has shown no inferiority in the overall segment, and in the bifurcation segment, in fact, seems to show better results than Zions. So on the whole, the long-term future should be good, having achieved a cross-sectional area which is 12.5 in the left main. I think the probability of ISR at any stage later would be extremely low. Probability of stent thrombosis also will be close to 0. So we are quite happy stopping at this stage unless you have some other idea.
I think it's a great result, and the stent looks well opposed. So what will be your dual antiplatelet duration for this patient, considering it's a biodegradable polymer in the setting of stable angina and left main angioplasty?
I think all of us in this particular area, I would continue DAPT cover for at least 1 year. All that the good coating on the stent at the end of 3 months suggests that if you may withdraw it for a little while if you need to, like if you have dental extraction, you can feel safe that you're withdrawing the DAPT cover. Show the previous view.
I think, yeah, I agree. Actually, being left main also minimum 12 months, but if it is like mid-LED, short stent or other vessel, we could stop it in 6 months as well. The ESC guidelines suggest if it is non-troponin rise.
Yeah, the Chicago meeting, the ACC, they actually came out with a DAPT score. Yeah. And the DAPT score depends on whether there is a risk of bleeding versus the risk of any ischemic event in future. And this gentleman at age 50 with nothing else, I think has got a good DAPT score, so there is no bleeding risk for him. So we can continue the DAPT cover for a long time. So this actually session was short DAPT versus long DAPT. And our patient with a good DAPT score fits into a long duration DAPT cover. So I would not hesitate. There are many of us who feel that ticagrelor or prasugrel may be a bleeder in longer term. Like if he has to have some accident, they bleed a lot. So maybe at some stage later you can make it soft, the DAPT cover, and switch to...
We've got just one comment from the panelist, and it's a great job.
Thank you.
Dr. Hiremath, I am Dr. Haq from Bangladesh, if you remember.
Yes, yes.
Ibrahim Cardiac. You did one case in 2008, left
Yes.
main bifurcation, including circumflex, and that was probably the first TAP procedure we did in our center. Recently, I did the angiogram, and he's doing well. The vessels are widely open.
Good to know that.
Just I have a query. You know, our centers always run short of hardwares. You said that if you do not have more than 4 balloons, then we'll put another wire and put another balloon and dilate. So does it cause an elliptical shape of the stent? And
yeah, I mean,
what is your experience? We don't. Never used it.
I don't do it. I mean, most of the time, as we're discussing, we do a 4-0 stretch. Like if this has not stretched, I would have taken a compliant 4-0 balloon and stretched it. 2 balloons together and doing them in a hugging fashion I don't know whether it will lead to some kind of stent deformation, but that's one of the options. I mean, so many times when we do a bifurcation, like you have 2 balloons which you're kissed, you bring them back and stretch the left main to a bigger diameter. So indirectly, many of us are doing it, though in this kind of case, very few people have done it. So indirectly, we continue to do it, and it looks quite safe. I don't think we should worry about it.
Okay, Dr. Hiremath, great job. And
thank you.
We'd like to congratulate you for the great case, and to your team as well. Thank you very much.
Now we switch